Welcome. This is Gary Swan from Healthcare Authority. We appreciate you joining us for this webinar. There's a slide description here talking about the audio options to make sure that you're able to hear us. And then additionally, if you have any questions, we'd be asking for you to type those into the panel. As we get those, we'll try to address them as appropriate. And we'll also have an opportunity to ask questions near the end of this webinar. I don't know if there are any other housekeeping. Actually, I'd like to do, just before we get going, a quick run around the room from HCA side to give everybody an understanding of who's in the room. So I'm Gary Swan from Healthcare Authority. I'm the lead for Alternative Payment Methodology 4 under our State Innovation Model Grant. We also have
Michaela Snook from the FQHC-RHC unit.
And Patrick Miles from the FQHC-RHC unit as well.
Mike Barabee from our Enterprise Data Management Analytics Group.
And then we have support staff.
Missy Healthcare Washington and Stella Healthcare Washington.
Great. So really the purpose for this webinar today is so that we have shared understanding around APM4. Today we're going to go over the basic APM4 construct and implications, what APM4 is designed to do, an overview of the quality improvement model and performance expectations. Additionally, we're going to be talking about the expectations for reporting and the processes around that, as well as talk about some of our targeted timelines to make sure that everybody has shared understanding around our targeted timelines. And then we'll dive into some of the common questions that we've gotten from APM4 participants and then go into a live question and answer session towards the end of this webinar. So before we get going, I'd really like to make sure that everybody has shared understanding, and I'm sure that I'm speaking to subject matter experts, but I want to make sure that everybody has a foundational understanding of what the current payment relationships are and where APM4 kind of comes from in a background perspective. So currently, FQHCs and RHCs are specially designated to receive special rates because you serve underserved populations and or rural populations. Because of that, an encounter rate is established for each FQHC-RHC. Those rates are independent from your sister FQHC organizations. There are specific requirements around what a qualifying encounter is. Most notably that it has to be with a designated provider, and that you can only have a certain number of visits within a 24-hour period of time. In Washington State, we have elected to adopt an APM. We are on the third iteration of an alternative payment methodology. And in short, all an alternative payment methodology is a new way to get to this encounter-based rate for participating organizations within that state. And it's important to note that this also goes through federal review and evaluation. So, as I mentioned before, Washington is on the third iteration of an alternative payment methodology. The first alternative payment methodology was implemented in 2009. This essentially took 99 and 2000 costs and averaged them out to get to an average rate. At that time in 2009, a Washington state-specific index was developed by Global Insights. And that trend factor was applied to your encounter rate. In 2011, the legislature came back and reviewed that trend factor, and for a period of time sent all participating FQHCs and RHCs back to their PPS rate, inflated by 5%. And then shortly thereafter, we have APM3, in which we use the same equation that was developed for the encounter rate under APM1, but we trended it by the Medicare Economic Index. So this slide really goes over the flow of funds for our FQHCs and RHCs. FQHCs and RHCs are not called out specifically within our Apple Health contracts in terms of their rates. So they contract, you contract in the same way that non-FQHCs and RHCs contract with our managed care entities. So we have premium rates that are developed for our Apple Health contracts, and FQHCs and RHCs have varying payment relationships with MCOs. Some of you are in alternative payment methodologies currently with your MCOs under a capitated type of arrangement for quality improvement, and others are under a fee-for-service type arrangement with quality incentives, but that is something that's a specific relationship between the MCOs and the FQHCs and the RHCs. To ensure that FQHCs and RHCs get their full rate, we generate a wraparound capitation, or in Washington State, we call it an enhancement payment. That enhancement payment is generated off of MCO rosters. So MCOs assign clients to an FQHC and RHC. Those rosters are reported to HCA. HCA generates the enhancement payment based off of those rosters. So we get the total roster count, and we estimate a visit rate based off of those rosters, generate an enhancement payment, and that goes to the FQHCs and RHCs. And to ensure that FQHCs and RHCs, according to federal provisions, were paid their APM4 or their PPS, we have to do an annual reconciliation. So that's where we true up the actual visits times your rates and the amounts that were paid. So for APM4, the core construct of it really is that we're trying to shift from this encounter-based system to a value-based system. The goal being that we're trying to provide flexibility to our FQHCs and RHCs to focus primarily on the care that you deliver and not focus necessarily on the encounter. So that you're focusing on quality-driven outcomes for beneficiaries and working towards managing your patient population, as opposed to building business practices around having that face-to-face encounter so that you can bill and get paid for the services that you deliver. Some specific examples of this would be nurse triage or standard operating procedures for your front desk staff to triage staff clients to perhaps move them to a lower level staff that can support that client without having to have a face-to-face encounter with the client. So really the goal of APM4 is to help shift the mentality and provide flexibility to our FQHCs and RHCs to align with the directions that the feds are going and that our state is going writ large towards value-based payment arrangements, and giving FQHCs and RHCs an opportunity to more appropriately contract on those value-based arrangements. It's important to note with APM4 that our FQHCs and RHCs receive no less than their APM3 or their PPS. This is a federal requirement, and we are dedicated and have committed to ensure that our FQHCs and RHCs participating in APM4 will at least receive their encounter rate. So if under an APM4 your number of visits goes up, we're still ensuring that our FQHCs and RHCs participating in APM4 will at least receive your encounter rate. FQHCs and RHCs participating have the right to opt in or opt out of APM4. The current payment relationships do not change under APM4. So that flow diagram where we generating enhancement payments and the flow of dollars does not change under an APM4. We will be updating we've updated FQHC and RHC rates, participant rates, but that flow, the flow of dollars isn't changing. So the rosters will still be reported up. We're generating payment based off of those rosters, and at the end of the year, we're still reconciling to ensure that FQHCs and RHCs have received at least their APM3 or their PPS. Under an APM4, however, we are not entertaining recruitment based on encounters. Rather, we're prospectively adjusting participant rates based off of their quality performance. So now instead of focusing on the encounter and reconciling and recouping based off of the visits, we're prospectively adjusting FQHCs and RHCs based off of their performance to quality improvement measures. So we are tying a subset of the common measure set to performance for our FQHCs and RHCs. Those FQHCs and RHCs that are able to perform on the measures will continue to receive their full PMPM rate. Oops, I'm sorry, go back up one second. Apologies, jumped ahead. So under APM4, we're converting APM3 to a baseline PMPM rate, which is your calendar 2015 APM3 rate times the number of encounters divided by your member months for that year. So those are the member months are the reported rosters from our MCOs, and that gets FQHCs and RHCs to your baseline PMPM rate. We're carrying that PMPM rate forward in future years, and we're trending it by the Medicare Economic Index and linking it to quality measures. The trending of the PMPM rate, we're also trending your APM3 rate so that we ensure that we're being true and reconciling FQHCs and RHCs to what they would have been paid under an encounter basis. So if an FQHC and RHC is able to perform to the quality measures, they'll be able to continue to receive their full PMPM rate in future years. If the FQHC or RHC isn't able to perform on those quality improvement measures, that it would be subject to prospective adjustment in future years, but never less than your encounter rate. If you're an FQHC and RHC, after being prospectively adjusted down based off your performance, are able to earn, perform back on the measures, that you would be able to earn back the full benefit of your PMPM in future years. The other piece that I would add to this, and we can discuss this in later slides, but the quality improvement model accounts for performance on a graduated scale, so both for achievement and attainment of the target, improvement and attainment on the targets. And it's also important to note that we, in our MOU, have mirrored what we have in our MCO contracts in terms of the dollars that are put towards quality. So even in total dollars under an APM4, only at least for the current performance year, 1% is the total amount that would be at risk for an FQHC and RHC, nothing more than that. So the difference between an APM4 and your total encounter payments, if it's greater than 1%, that 1% is the only amount that we'd be prospectively adjusting your rates on. So you have a question, what if our baseline rates are already high quality? We'll talk about this a little bit later. If you're closer towards the target, you're recognized more for attainment of that target compared to improvement. So this here, again, is just another way to visualize what the APM4 does under your encounter basis, encounter-based payment methodology. If you had 3 billable encounters, it comes down to 3 billable encounters. Under APM4, a value-based payment, you can replace some of those encounters with what would be non-billable type visits and still be able to receive full payment. So when it comes to reconciliation, under APM3 or PPS, you'd be reconciled to 3 billable encounters. But under APM4, we set your baseline PMPM rate and we're trending it forward relative to everything else. And you would have 2 billable encounters, but we'd still pay you the trended amount of your baseline. So those billable and non-billable encounters, that difference between your PPS or your APM3 would be linked to quality improvement measures. And those are the same 7 measures that are in the Apple Health contract. This is one other way to visualize what APM4 tends to do. And I'd like to underscore that this diagram isn't to scale, and additionally note that 1% of your total dollars are the only dollars that will be of your wedge, or the difference between encounter-based payments and your PMPM-based payments are the ones that would be dollars that would be put at risk. But the intent really is to focus around your primary care team and have your PCP be able to manage potentially more clients, so expanding the market share for SQHCs and RHCs, or decreasing your relative visit rate so that you're able to manage a larger patient population and or reduce the number of direct face-to-face encounters you have with your primary care physician. And in doing so, a focus on managing population health and managing the patient population. So this is the basic construct for APM4. We're going to go into the quality improvement model next, but I'd like to pause for a moment and ask you if there are any additional questions on the financial construct for APM4. So I'm going to give just a minute on that. There's some questions coming in. Just give us a moment to copy them down. So we have a question. What is the process if after the reconciliation the full rate has not been received? So in reconciliation, part of that is to ensure that in reconciliation, part of that process is to ensure that our SQHCs and RHCs have received their full rate. So we will be truing that up in future years, and I would defer to our financial services team to offer additional clarity in the coming weeks and months on what that specific process will look like for next year to ensure that our SQHCs and RHCs have gotten their true rate. So we have a question. Slide 11 says Q1 improvement and attainment on 7 HEDIS measures. No one is likely to attain goals on all 7 measures. Do you only get value-based payments when you meet all 7? So let's really shift to the quality improvement model, because I think a lot of those questions will be addressed in the upcoming slides. We have another question. If a cost report is filed in future years and any reduction in encounters under APM4 would alter visits recorded on the cost report, is that correct? It would, I mean, your encounter basis, it would change, but we're trending you based off of your baseline PMPM rate and comparing your APM3 to your PMPM payments to ensure that you've at least gotten your encounter-based payments. So if there's a difference between that, then we would prospectively adjust up to 1% of those total dollars on your rate in future years. Okay, how does a change in scope affect the PMPM rate? Does it mean the rate is recalculated using the new per encounter rate and the encounters in the year covered by the change in scope? So under our MOU, if a change in scope is filed, what we essentially do is we will, still according to change in scope provisions that are in statute currently, we will recalculate what the baseline PMPM rate would be using 2015 utilization and your new encounter rate, and then trend that forward to the current year. Essentially, we'd be updating your APM3 PPS rate according to provisions, and then recalculating what your baseline PMPM would be and trending that forward. We have had some discussions with Steve Clark and with Bob Marcelli from LACMAC, and it's on our radar, and we're committed to following up on the change in scope questions as it specifically relates to APM4 in future years. But that information will be forthcoming as we begin to work through that. So for the quality improvement model, these are the 7 measures. Antidepressant medication management and medication management for people with asthma each have a sub-measure. So ostensibly there's 9. We are asking for the SQHC and RHCs to self-report on diabetes measures and childhood immunization. HCA is generating the administrative measures or the claims-based measures. Those measures are generated based off of the NCO reported rosters. So the rosters that were reported up to Healthcare Authority, we run that against continuous enrollment and continuous assignment, and then HEDIS specifications to get to the measure rates for 5 through 7. For measures 1 through 4, we have used continuous assignment and continuous enrollment, as well as some other claims-based information to get to what we've designated as a provisional cohort. So based off of what we can see in claims, those clients that could potentially fall into the final denominator or numerator for diabetes measures and childhood immunization. So it's important to note for the quality improvement model that participants are compared against their own baseline. The quality improvement model compares the performance year to the prior performance year. So we are perpetually going forward, we'll be comparing each participant to their prior performance year. So right now, the performance year is 2017. The prior performance year is calendar year 2016. We used roster information from calendar year 2016 to generate the administrative measure rates and to generate the provisional cohort for the self-reported measures. We are linking the quality improvement model based off of a composite score to FQHC/RHC's PMPM rate. So we're going to talk about this in greater detail, but the quality improvement model rewards both lower performers and higher performers respectively. Those that are lower on the scale in terms of performance are recognized more for their improvement, while those that are closer to the targets are recognized more for their attainment on those measures. So we're looking at NCQA, I believe it's 2015, MCO 90th percentile standards for our targets and our means. The weighting for each of the measures, as you'll see, are evenly distributed across all of the measures. So we have a question to validate. To validate, we only need to run reports on the FQHC reported measures, and the rest will be generated by claims. That's correct. So we're looking at a minimum for our FQHCs and RHCs to validate and report back to self-reporting measures. Under APM4, as I mentioned, we are looking for our FQHCs and RHCs to move towards managing the population that they serve according to the quality improvement model. So it would be maybe helpful for an FQHC and RHC to look at and reconcile the administrative measures, one, potentially to raise questions that you might have within those, but two, so that you're starting to build processes to manage to those measures. But I would say that it's not in a requirement of the payment methodology this time. So the question is, continuous enrollment is used on all the claims measures, but is or is not used on the FQHC measures. Continuous enrollment and continuous assignment is used on all the measures, and that's for 11 of 12 months for the performance year. So the question, there are many questions regarding the reporting requirements for the quality reporting. How will the clinics reconcile detailed specifications for the reporting criteria that we will be required to submit for the clinic-generated reports? So we've listed the specifications for each of the measures within the spreadsheet that was delivered to you. They outline in that spreadsheet the qualifications for the numerator and denominator. If you have specific additional questions, or if there's additional input that is helpful or needed to clarify the requirements or what you need to do on your end to run those measures, we're happy to connect you with support staff that can give you more details on the specifications for each of those measures and how to generate that. Additionally, going forward, this is the first run. We want to work with our FQHCs and RHCs to ensure that you're getting the information that you need to be able to run these measures. And we are happy to update and modify the spreadsheet or the supplemental information going forward in the future. So question, 90th percentile. Wow, our contracts are more targeted at the 75th percentile. So I think it's helpful to walk through this model to give a little bit more clarity to why we've chosen the 90th percentile, and it'll make a little bit more sense why we've selected that as for our targets and our needs once we kind of step through this. Additionally, I would encourage you to go out and take a look at the full webinar on the APM4 quality improvement model if you have additional more detailed questions about this going forward. So for the quality improvement model, we have the weights that are evenly distributed for antidepressant medication management and for medication management for people with asthma. We split that so that is one measure. So it's 7.14 as opposed to 14.29. We have the targets and the means, as I mentioned. We have the weight for the quality score. So what this is a dynamic weighting between improvement and attainment. So if you are below the mean for the measure, then 75% of your score goes towards improvement. So I'll say that one more time. If you're below the mean for the measure, then 75% of your improvement score is weighted towards your improvement score. 25% would be weighted towards your quality score. Once you are above the mean, then that becomes dynamic. So if you look to the first measure, both the performance year and the prior performance year are below the mean. So 75% of the 0.07 goes to your final quality improvement score. So 75% times that 0.07 gets you to 0.053. If you go to the next measure, where you're crossing, you're above the mean, you can see that this quality score has changed because it dynamically weights between the quality score and the improvement score. So 34% goes to your quality score, and the difference of that goes to your 66% goes to your improvement score. So because the prior performance year and the performance year, there was no improvement on that measure, you still get 0.27 times that 0.34 gets you to that 0.092 on your performance. Jumping down to well-child visits. So under this one, the prior performance year was below the target, and the performance year moves above the target. So when 100% of your score is towards your quality. So that gets 1.52, and that transpires over to your score for that is 1.52. So it's important to note that there's dynamic weighting once you get above the mean, and that it's a relative weighting between both the improvement score and your quality score. So all of this, your 0.053, your 0.092, your 0.15, all gets multiplied by the weight for that measure and gets rolled up into your quality improvement score. The quality improvement score is only positive, so it'll go from 0 to 2, I believe is where it tops out. But we're looking at 0.2 as being the target to get 100% for APM4 performance. So all of this gets rolled up into a composite score, which is your quality improvement score, and 0.2 is 100%. So because of the way that we've designed this quality improvement model, it makes it easier and more dynamic for those that are at the low end of performance to progressively work and improve, and for those that are at the high end of the scale, for them to perform. So I'm going to go over some of the questions that have come in. So the question is the mean half the 90th percentile? If that is the case, then that makes more sense. It is not half of the 90th percentile. It is the 90th percentile. And again, because we're looking at having 0.2 on the quality improvement score be the 100% for your performance in APM4, that's part of the reason why we've elected to have the 90th percentile. And this is the same targets that we have for our MCOs. And I think you can go out and take a look at those contracts to see that. And again, emphasizing that you don't have to perform on all of these measures to win out on your quality improvement score. So if you take a look at your population and you have programs that are already focused on diabetes management, and you have a large percentage of the population diabetes that you're working with, you can focus primarily on those measures and still win out on your quality improvement score because of the dynamic weighting between both the attainment and the improvement. And again, needing to get to that 0.2 on your quality improvement score to get 100% on your APM4 performance. So the question, as I've gone through the roster provided, there's some patients that we have never seen, some that we didn't see at all in the 2016 timeframe, and some that have never had a diabetes diagnosis but are on the first measure. Should we mark those with rates on the side? So the client assignment question is one that we are still discussing internally. We would like for you to report out both if the client was not assigned to you, but also this is a provisional cohort. So you need to tell us if the client falls into the denominator and had care delivered in 2016. Go ahead.
And probably taking that further, also they were actively assigned to the facility.
Yeah. And we'll talk about that in a little bit more in the coming slides, but if there are additional questions, we can follow up either offline or, and as I mentioned before, in our previous emails, we're going to be doing a regularly scheduled conference call to address and some of the immediate concerns as well for participants. So there's a question that it's unable for some providers to match up based off of the spreadsheet information. That question has been raised, and we are looking to add in future iterations with a DSA update, additional client information, which would be the last plan ID and the plan name, so that providers can match those clients up. If I haven't been in touch with you, please reach out and I can additionally work with you on that. But if you are able to reconcile this information and report out on the information that was provided, we ask that you continue to work on that. But we are working with several providers to ensure that we're getting some updated information to folks. So please expect those updates in the future. So question, I might have missed the comments, but the quality scores are based only on those that have 12 months continuous enrollment with the center. We're looking for 11 of 12 months for the clients that have been with the SQHCRHC. And the information that we've provided to you, to the clients that have identified, we've already run those clients against continuous enrollment and continuous assignment. So we're going to move on, and if you have additional questions as we go through this, please continue to send those along. For the rate adjustments, I wanted to outline the timetable so that everybody make sure we all understand what the timing of this looks like. So this basically outlines the timing for performance and the timing for rate adjustments based off of the PMPM. So we are currently in performance year 1. Prior performance year is 2016. In 2018, we're waiting for claims runout, and we will calculate the SQHCRHC's quality improvement score in 2018. Additionally, in that year, we'll have reconciliation for 2017, and we'll adjust the PMPM rate for 2019. So 2019, 2017 performance will go into, 2017 will go into effect. So 2017 performance compared to 2016, your rate will be adjusted in 18 and go into effect in 19. So I wanted to outline additionally the reporting processes. We have 2 reporting processes that we are working on. The one that everybody is diligently providing data for right now is our mid-year reporting for quality improvement scores. So this is your actual performance for a prior year. But we additionally want to give SQHCs and RHCs a glimpse into the current year performance measures so that you know who could potentially fall into your cohort in future years or in that performance year, so that you can implement quality improvement programs. You know, if you need to do child well visits is an easy example. You can begin to identify those clients, bring them in so that they fall into your numerator and that you're able to begin improving scores on that. So there's 2 pieces to this. So there's a mid-year reporting, and then beginning of the year and towards the end of the year, we're going to give FQHCs and RHCs a glimpse into the current year performance. And that would be the total potential population for that second piece, the total potential population that could fall into your denominator for your QIS reporting. So this gives a little bit more detail just on the reporting process for the QIS scores in future years, and this timetable is targeted for future iterations. We're working right now with all of our SQHCs and RHCs and recognize that it's a lift to report this data back out, so we're working with folks on timetables for this year. But in future years, it's our target to move towards a July to September reporting timeframe, that we'd have data reported from HCA to the SQHC, RHC, and then have data reported back from the SQHC, RHC back to HCA. And this would be, the scope of this data would be prior performance year. It would be generated from those reported rosters from the prior year. That the data would include the same type of information that we've included in this reporting. So it would be run against continuous enrollment, continuous assignment, and then HEDIS specifications. And the sole purpose of this is so that we can get to baseline performance for the current year, so that we can report out on your QIS scores. So that's going to be 2016. We're working on that right now to get 2017, we're working on that right now to get 2016. 2018, we're going to be working on mid-year reporting to get 2017, 2019, 2018 reporting, and so forth. So this is the second data reporting piece that we're going to be providing to SQHCs and RHCs. And again, this is solely for population health management. Providers are not expected to return this data to SQHC or validate it or vet in any way. This is solely so that SQHCs and RHCs can get a look at what their potential performance might be in that current performance year and identify who those clients might be, so that you can start to implement quality improvement programs that help your performance for that current year. So as we have implemented this PAM methodology in the second half of 2017, we're going to be reporting out in October a current look at 2017 information for SQHCs and RHCs to see who potentially might fall into their cohort, both for the self-reported measures like we have reported out for 2016 and for the administrative measures. So it's going to be a current year look at data for the purpose of population health management and to help you perform in the current year. So I have a question. Do we have to report on beginning and end of year? We have other methods of evaluating quality performance without going through the onerous data collection of this program. So as I mentioned before, we're not asking for reporting beginning and end of the year. This is solely for SQHCs and RHCs to get a glimpse at what their potential performance might be and to help you to identify those clients that might fall into your numerator or denominator and improve your outcomes. In terms of the reporting pieces, we'd be interested in having additional conversations on how we can make this more streamlined to support with either additional information on clients. But at the end of the day, we're looking for our FQHCs and RHCs to, at a bare minimum, report back on the self-reported measures to HCA so that we can get your scores based off of your EHR data for your performance on those measures. So for the reporting timeline, and so this is the current data process that we're in right now, and I'll talk about timelines here in a minute. But in future years, the iteration or the process flow will be that HCA would deliver a first set of data, and it would be akin to the data that we've delivered this year, that the FQHCs and RHCs would review, populate the self-reported measures, and to the extent that the FQHC RHC is interested and willing, review the administrative measures and report back to HCA. HCA will take a look at that data that's been provided by the FQHCs and RHCs, and will finalize your QIS scores. And again, this process would start in July. And the reason that we have that mid-year kind of reporting process is because we want to make sure that we have the prior performance year claims run out so that we have all the data that we can get for the administrative measures to make sure that they're the most accurate. And again, this is another visualization. And if you have any questions on the encryption or decryption process, please refer to the document that I've already sent out in previous communications. But again, this would be for quality improvement score. The first is data reporting. HCA would send to the FQHCs and RHCs. The FQHCs and RHCs for the second portion of that would report back to HCA. And then HCA would finalize and send those scores back to the FQHC and RHC. So in this process, I do want to call out that and thank everybody for working with our data security team to set up PGP encryption. But in this process, HCA will be encrypting all of the data, the spreadsheets per our data sharing agreement, uploading them to a secure server. QHCs and RHCs go out and grab that data, download it, and with the PGP key, decrypt that data. And when an FQHC RHC is to send this back to HCA, that reverse encryption process will need to happen. So an FQHC RHC will encrypt that data, upload it to the server, make sure and let HCA know that it's been uploaded so we can go grab it, and then HCA will download it and decrypt that data. The last piece I'll say on this is if you have any questions, please make sure to reach out, and we're happy to add additional people to notify our FQHCs, RHCs that the data has been uploaded. And I do want to note that there's a 14-day window, and the servers are scrubbed on a regular basis on a 14-day turnaround. So if we upload the data to an FQHC, RHC, you have 14 days to go out and grab it. And the reverse is true for when you upload data for HCA to go grab it. And so this is a timeline for the beginning and end of year reporting. And again, I want to underscore that these reporting periods in March and October, their current year looks, and there's not an expectation that an FQHC or HC is to review this data and send it back to HCA. This is solely for an FQHC or HC to get a glimpse at what the potential population might be for their performance. So I'd like to thank everybody additionally for their flexibility in the timelines. These are targeted dates that we have outlined. In our first iteration, we sent the FQHCs and RHCs, we sent you all the spreadsheets that you're working with right now. It's our hope that our FQHCs and RHCs would be able to review and report back on the self-reported measures by October 6th. That would give us some flexibility on HCA side to make sure we review that, work through any additional questions, have a conversation with those FQHCs and RHCs that need to discuss the measures, and report out on final QIS scores. I do want to highlight at the bottom of this page, and we'll discuss it later, if I've worked with you or I've been in communication with you, or if you're not able to meet these timelines, please just reach out to us so that we can work with you. It's my goal that we would finish this back and forth process by December 31st of this year, so that at least by the end of this year, we have everybody participating in APM4 to their quality baseline. So if you have questions, or if you have issues, if you're waiting on information from HCA for an updated DSA or an updated data set or other information, please, if I'm not already working with you, reach out to me so that I can work with you, and we can set up some of those additional processes to get everybody to their quality baseline. But if you're able to meet these timelines, please try and work towards that and help us get everybody to quality improvement baseline as early as possible. So I wanted to go over some of the expectations on the data processes. Review and reconciliation of the data is important, both for your performance and for us to raise any questions or issues that you have with the data, so that we can work with you. For the self-reported measures, really going through and identifying which clients fall into the numerator and denominator. We're asking that you denote that with a 1 or a 0, simply that 1, they meet the criteria that's listed for the numerator and denominator in that spreadsheet header. 0, they do not meet that criteria. If you have issues around the client being seen by that FQHC, if you can't find them, or if you have other questions, please denote that to the right of the data field, or if you need, generate a new tab. But we just need to be able to map that to the data that has at least been provided, so that we can do our own reconciliation on some of that data. So I have a question here. We need a different run on spreadsheets. October 6th is not very realistic with the current sheets, unless the expectation is hand chart audits of thousands of charts. And something October 6th for the hand chart audits won't hit that target. Yeah, so we recognize that this is a difficult timetable, and that there's additional information that needs to be provided to some providers to be able to reconcile this information, and that we're working on a DSA update and working with our CMO to finalize some of those pieces so that we can get out some updated spreadsheets. I do want to highlight that we are wanting this to be as automated as possible. We agree that it's not realistic to go out and do hand chart audits for each of the clients that are listed in the self-reported measures. And if they're needing to look at the EHR, we're looking for each FQHC RHC to go out and be able to look at their EHR and use that information to reconcile the information and report back to us their performance. I would say that we are, if it's a HEDIS specification, I'm not as familiar with the specifics and details of HEDIS as our subject matter experts, but if that is a specific requirement of HEDIS, we are looking for this to be as automated as possible, so that it's something that you as a provider can develop your own run charts and be able to report back to us on those measures. And if there's some support or there's some other questions that you have on the specifications around the measures themselves, it might be easiest to set up a direct conversation with our subject matter experts here that work with HEDIS and work with quality improvement to help address some of those specific questions. But we do want to underscore that we want this to be as automated as possible, and that we're not looking for our FQHCs and RHCs to be going out and doing hand chart audits on thousands of clients to report back to us. And again, this is just to highlight, if you're unable to meet the timelines, either due to you're waiting for HCA to move, or you are simply unable to generate the processes to run the measures and need an extension or anything like that, I just ask that you please reach out to me so that we can work with you on those timelines. And as I mentioned before, I want to get us through this iterative process of back and forth between FQHCs and RHCs participating in APM4, HCA review and finalizing the QIS scores by the end of this year. It'd be my preference that we don't have, we're not working through this in 2018, trying to establish 2016 baseline performance, that we're able to complete that process by the end of this year. And again, if you have any questions on the encryption or decryption process, or if you need us to add additional people to notify you that the data has been uploaded, or that you've uploaded it to us, please reach out to us and we'll make sure and update those or help you work through processes from our data security team. So these are some of the questions, the common questions that we've gotten from the participants in APM4. And I'd like to step through those now. So the performance period is calendar year 2016, January 1 through December 31st. It's been noted to us that in some of the spreadsheets, it calls out specific HEDIS specifications, I think for July of the performance year or something along those lines. We're looking for the entire year of 2016. So at least in terms of the time frame, we're looking for self-reported between January 1 and December 31st of 2016. The field that was designated billing provider, NPI, we're not asking for anybody to populate this field. This was intended to be tax ID, and after we went through some of the data security questions, we were unable to report tax ID and need to update our DSA to reflect that. And in future iterations, once we get DSAs updated, that will include tax ID for each FQHC and RHC, as opposed to looking at the billing provider NPI. And that aligns with the billing procedures that we have from the finance side of the house. So if you have different numerator denominator information, we want to know this. We want to know if what you're seeing is different from what's been reported. If there was service delivered that we're not seeing, please highlight that in additional columns to the RILA spreadsheet or in a separate spreadsheet so that we can map it back. In short, we want to know if you have some specific issues or have questions, or if there's different rates that you're seeing. But if you do see a difference, please try to call out what that difference is in the supporting column, or any additional columns. So the questions come, what is the selection criteria? So again, we use the MCO rosters, and we're looking at a continuous assignment and continuous enrollment for 11 to 12 months. We're using MCQA HEDIS specifications, and those are for the administrative measures or the claims-based measures. For the self-reported measures, we're looking at available claims information to get us to what we've denoted as been calling a provisional cohort for those measures. It is agnostic of where service was delivered. It looks specifically at the assignment rosters. So the client was continuously assigned and continuously enrolled with your FQHC for that period of time. It does not look to see if that service was delivered at your FQHC-RHC. And again, this issue or this client assignment question has been raised to our CMO, and we're working through some recommended solutions for that. I would suggest, and this is what's been articulated by our CMO, that our bias is for the FQHC and RHC, or for the payment methodology, in the payment methodology. So we want to make sure that we are being consistent across our performance scoring, but that our bias is to favor the participants in the payment methodology. So we're working on a recommended solution for that, and as we have more details and have that finalized, share out additional information on the client assignment. But if you would like to call out that they were not assigned to you, please denote that to us, and we'll take a look at that information. Yeah, and this is the subsequent question on the assignment piece. So please denote that to us. So I have a question. We elected not to participate in APM4 because we achieved a major influx of new patients based on enrollment efforts in 2014 and 15. Our visits per member per year were artificially low during this period and are likely to rise in subsequent years as we effectively engage with these new individuals. We believe that our visits per member per year will rise. Will the HCA adjust the baseline for new FQHCs who wish to enter into APM4, or will the baseline 2015 visits per member per year be retained indefinitely? This question gets back to our change in scope issue. So I think that we recognize that as a specific issue that needs to be addressed for a change in scope specific to APM4. Again, we don't have solutions devised as yet to that specific question, but we'll be looking at addressing that in the coming weeks and months through your association and designated representatives. And again, these are the issues that we've raised, at least right now, to our CMO, and that we're working on solutions. Hopefully we'll have some of this finalized this week so that we can get this out to folks and have more clarity around performance. So updating the DSA to include additional information and fixing that billing NPI issue, working on the small sample size. So if we get down to 30 or less clients that qualify for the measure, according to HESA specifications, 30 or less, we drop the measure, because it's not statistically valid to denote that that performance is from the clinic, and we have no way of knowing that was just an arbitrary performance. And then client assignment question. On the sample size question, and just to refresh everybody with our MOU, we will drop the measure if it's 30 or below, and evenly reweight based off of the remaining measures. If we start to drop 2 and 3 measures, we will be directly engaged with the FQHC-RHC to see if we want to develop a proxy measure, or if we want to just redistribute, or how we want to address that. But I think that what our strategy is going to be is just to work directly with our providers to make sure that we're reaching a solution with that on a case-by-case basis. So this is a lot of information. and I've tried to address the questions that you've raised to the best of our ability, at least with the knowledge that we have right now. Are there any questions that folks have on APM4, both with the basic construct, what our goals are, with the quality improvement model, and or our reporting processes? So I'm going to give folks just a minute to see if there's any additional questions right now. So we're going to go ahead. If you're in the process of typing questions, please continue, and we'll address those as those come in. So as I mentioned before, we're finalizing our questions on the key data issues. We have a regularly scheduled conference call. So we've tried to open what I've termed previous emails as kind of open office hours for our APM4 participants. And that will be from 11 a.m. to 12 p.m. every other Monday starting October 2nd. We'll have subject matter experts from the policy side. We'll have finance folks there. We'll have our quality improvement people there, as well as our data security folks to address questions. At that time, we'll give any updates, timely updates on APM4. So any new information that hasn't already been released and probably has been released to make sure that everybody's on the same page, sharing those updates, and then we'll open it for question and answer. For these sessions, we are going to only host them for as long as necessary. So we'll share our updates at the front end of the conversation, and then we're going to open it up for question and answer from APM4 participants. And then if there are no questions, or if there are questions that we need to take offline, as soon as we address all of those, we'll end the call. Unfortunately, we'll be unable to record those questions, so we look forward to your participation. And as I've mentioned previously, if you have questions, or if you have issues, or if you just need to address something, please make sure and reach out to me so that we can work with you on those specific issues. So the question, I thought the first spreadsheets we're using were NQF measures. Are we using HEDIS? I'm going to hand that over to our subject matter expert on the measures piece of this, on what specifically they are.
So we are using the HEDIS specifications in order to build the measures from claims. And the NQF number was provided as a supplement to for the entities to understand the methodology, etc., as the it's available and provided as a link in order for entities to understand where the specs are coming from. But the specifications used for the administrative measures, claims-based measures, are at this time for the data supplied for 2016 measurement year were based on the 2016 measure specifications from here.
Thank you. So I have a question, will APM4 be required for FQHCs next year? No, APM4 will not be required for FQHCs next year. This is an opt-in, opt-out payment methodology. And again, this is a pilot. We are committed to making sure that APM4 is a success. But what that means is that we're working with WACMAC and working with participants in APM4 to ensure its continued success and longevity. But it is, as other APMs for Washington State, an option. So you can opt in and opt out of APM4. So you have the question, do we have any answers about the timing for change of scope? As I mentioned before, we don't have any specifics yet for the change in scope. I'm working with WACMAC and your designated representatives on the change in scope process. For those of you that are undergoing or have undergone a change in scope process, we are following the current WAC procedures. So we're adjusting recalculating your rate. That'll be your rate going forward for your APM3 PPS rate. And we will be taking that rate using 2015 utilization to recalculate your PMPM baseline and trend that forward by the MEI for any time differential. So that at least is the current process. And again, we recognize the need to address the APM4 change in scope question and issue. And I'll be working with the association and HCA leadership on that. I would also, just as another note, state that HCA leadership is committed to APM4 longevity and success. I know that we've had some transitions recently, but our finance team, Medina and company, have been highly committed to ensuring a successful transition to APM4 and are happy to work with you on any financial issues that you have. Our data team has had strong support in ensuring that you're able to get the data and that we're following our data security procedures and can work with you. And then additionally, from our policy shop, Laura Kate Zeichkin, who is our interim director for policy, is highly committed to the TAMP methodology and ensuring that we are successful in implementing it. So from a leadership perspective, we are still 100% engaged and committed to working through this with participants. Parting thoughts, unless we have additional questions. We are finalizing our responses on those key data questions, and we're working with our CMO and with our data quality folks here in HCA to work on that. Please expect that to come out soon from HCA, and keep on your calendars. I'll send out an invite after this webinar. The APM4 conference call, regularly scheduled conference call. I encourage you to please join that and ask questions. And again, please reach out directly if you need immediate assistance on anything APM4 related. Again, my email is gary.swan@hca.law.gov. And this is just a parting reminder for APM4 participants. According to our MOU, we've set the deadline for 2015 reconciliation for October 15th, 2017. So finalized reconciliations are due to Medina's team by October 15th, 2017. And I just wanted to remind you all of that. And then lastly, I'd just like to thank everybody for participating in APM4, working with us. You're all becoming experts on this value-based payment methodology, and I really appreciate that. And I also very much appreciate your timely turnaround on the value-based purchasing surveys that will help inform our purchasing strategies in future years. So thank you very much, and have a good day.